Ladies and gentlemen, welcome to this latest teaching session on the course on technology and the future of medicine. Today I have some really good news for you, which is that the Faculty of Medicine and Dentistry has decided that this course can be an official elective for first and second year medical students, and that's going to have a big positive impact on the course. It's kind of logical that we would have medical students in the course since I'm from the Faculty of Medicine, but we really have not ever had medical students taking the course for a grade. So it's a very positive development. The other thing to tell you, which is a little bit amusing, is that the effect on the lecturers in this course of watching their own videos is quite variable and heterogeneous. Some of them can't watch themselves on video at all. It's an experience that they just feel that they can never have. But Earl Wah had never watched himself on video until yesterday, and he watched his talk from the 7th. And he decided what he really needed was a kind of tag team with a younger guy. And he's picked Abdullah, our lecturer today, as the person he would like to do a tag team with. So if you can imagine the lecture that he gave on the 7th as a sort of ping pong, intellectual ping pong, right? Going back and forth between young person, old person. So that's what we plan next time. It's a really exciting concept, and it proves that the course continuously evolves, which I know I keep telling you, but you may not always believe it. So anyway, I'm in a very good mood also because Abdullah is one of our best speakers, and he gave the best talk ever in his life, I think, on the previous time when he spoke on a university holiday like this. So there's something in the stars that when there's a university holiday and we're supposed to cancel a class and we don't, and he speaks, it's just an awesome experience. So no pressure or anything. No, I'm really looking forward to today. So Dr. Saleh is going to talk to us about technology and global citizenship. So take it away.
Thank you very much, Dr. Solez. Thank you all for coming today. I know it's your day off, and I'm very impressed you all came. No pressure at all, Dr. Solez. Thank you for setting the stage. I think some of you might have seen previous videos of me speaking, and I tried, instead of giving the same talk, is to contextualize the talks that I'd given a little bit more, to flesh it in this context of both global citizenship and the singularity and these concepts. So I hope you'll bear with me. I was on call last night, haven't slept, so who knows, this might be a bit of a trip for everybody, so we'll see where we go. So a little bit of an agenda. I want to focus today a little bit more on the idea of urbanization. And from there, talk about how urbanization has led to a lot of environmental pressures, how the concept of singularity and society are maybe interlinked, and more as it relates to my experience as an individual and as somebody in an organization that deals with these informal settlements, also known as slums. I'll talk more about what slums are, what they mean to society, and where we're going with them. I'll talk about AIMS, which is a very exciting organization and with very exciting initiatives. I'll talk about IC Change, which is the organization that I helped found, and I'm the Chief Executive Director of right now. And talk about some of the projects that I had outlined before, so just bring you up to speed on some of these projects, and then talk about how we're heading towards sustainability in these projects, and maybe some next initiatives. I hope we can have a little bit of a debate and some discussion, so please feel free to ask questions and get a discussion going. So, urbanization, I'm sure many of you know what urbanization means, but it's the movement of people from rural areas towards urban centers or cities. Now, this is a train in India, in Mumbai, and this is, you can see a very densely populated train station with countless people, and I'm not even sure this is rush hour. So they're all trying to get on. I'm not sure how they'll fare. But I think a lot of you have seen this countdown to the singularity, and I took this slide from the singularity.com's website, and it just talks a little bit about, how life started out here, and then how we got the eukaryotic cells, we get mammals coming in, human ancestors walking upright, then Homo sapiens, and then Homo sapiens sapiens, and then agriculture and the beginnings of industrialization, and then computers, and personal computers is kind of the pinnacle of where we are right now. And that talks about the increased integration of technology and increasing computing power as we move towards this described and defined, but often nebulous concept of the singularity. I want to talk about Jared Diamond's book, Collapse, and how societies choose to fail or succeed. Has anyone read this book before, or anyone heard of this book before? So it talks about how, in a way, it challenges the idea of singularity in saying that as societies get more complex and as we move towards more and more technological advancements, we exceed or outstrip our resources and end up collapsing. And so he brings into account different examples like the Roman Empire and even the United States as an empire that is, and the intervals between these empires is getting progressively shorter. So does that mean that the singularity will not happen? Is it one of those things where you're always trying to approach it or nearing it, but societies fail time and time again at ever getting to that point? So we'll talk a little bit about some maybe opinions, and I won't say there is a lot of backing to this, but of things that we've done as an organization that I think might speak to this idea. So this is just a description of the singularity in space and how in black holes the singularity is seen as this almost vortex of infinity. And but we don't need to get into the physics. It's a holiday, so we're not going to go there. So urbanization. In reviewing 150 years of globalization, it's pretty shocking statistics. So going from 14% back in the 1900s of people living in cities versus rural areas to, in 2008, for the first time in human history, more people or the same amount of people lived in urban areas as they did in rural areas. And that's a staggering statistic. And it might seem like, okay, well, they're moving to cities this is going to advance societies and build more technologies and better, more fruitful outcomes. But at the same time, it does have a lot of detriments. And looking at that trend and the ever-increasing pace of that, by 2050, they're expecting 70% of the world's population, which is ever increasing, to live in urban cities. Now, urbanization didn't happen at the same rate all over the world, and you can see from this graph that the United States got to, this is the 50% line is the red line in the middle. The United States surpassed that way before 1950s, and other countries like Brazil surpassed it by 1965, whereas some countries like India and China are gonna approach it, and China has just recently surpassed it. And there's a lot of economic, health, and societal impacts that come from urbanization. This picture, which is again in India, really I think portrays this idea of urbanizations and the challenges of urbanizations and this concept of slums, which we'll talk about next. You can see she's walking along one of the big sewage pipes, and on her left there is a pile of garbage, and on her right there is all these informal settlements and housing that a lot of people live in very densely populated conditions. And this fine line that she's walking between what is a culture and a society that is on her right and the complexity of that society versus really the encroaching waste and environmental damage that's happening on her left. And I think that this is, unfortunately, and maybe this is our time to act, going to be the new normal in most of the world. So UN Habitat defines slums very broadly, but it doesn't define it as the presence of something, but more aptly the absence of something, which is, in this case, the lack of one or more of these things, which is durable housing of a permanent nature that protects against extreme climate conditions, and you can see how those tin shacks might not really protect people. Sufficient living space, which means not more than 3 people sharing the same room. In most of these slums, over 9 people live in rooms as small as 6 by 6 feet. Easy access to safe water in sufficient amounts at an affordable price. That's probably one of the single biggest barriers in most peri-urban environments or informal settlements, and mostly because as these societies grow, the governments or the urban planners don't ever get the water and the sanitation infrastructure laid in so that they actually benefit from it. So they very quickly outstrip the access to safe water and protected water sources. Access to adequate sanitation in the form of a private or public toilet shared by a reasonable number of people. And if we were to see the number of people sharing an individual toilet in a place like Kibera, in one of the slums in Nairobi, some estimates go up to 2,500 people per single public toilet. And I mean, you can imagine just probably if those of you who have roommates, try imagine waiting for the bathroom, now share it with 2,500 people. Security of tenure that prevents forced evictions. Land ownership in most of the world, really, I won't say the developed world, is in a way a monopoly by a very select few, particularly in the low and middle income countries. And it leads to very difficult circumstances and lack of security for a lot of these individuals living in peri-urban environments. So they don't own the land where they've built this shack, and at some point if developer comes and says we're going to build a mall, they evict everybody in that slum or in that environment, and then where do these people go? Now this idea of, now I described a very kind of dire picture of what a slum is, but slums, I mean, there's this concept of slums of hope or despair. So what I mean by slums of hope was a concept that really said that these people are coming willingly. They're leaving their rural areas, leaving their agricultural lifestyles, and moving to the city in search of a better life for them. Better income, schooling, better access to technology, and hence that's what those very rapidly expanding slums in, let's say, East Africa are characteristic of. So they grow very quickly. They represent a net migration of people from the rural areas coming in, searching for a better life. And overall, you can see the demographics of these slums are, and I don't want to use slums because it has a lot of derogatory connotations to it, but this peri-urban environment or informal settlement has a very youthful and energetic culture, and while it does have a certain element of crime, they are overall a very innovative and entrepreneurial bunch. The other side of things is a slum of despair or a peri-urban environment of despair. And this is when a community or an environment has outstripped its resources, or there's been a new industry that has moved in that has completely destabilized the net income of this population, and then they start to not be able to provide for themselves, and then things start to collapse. So that's really the two types of slums if we were to classify them. Because it's not just how the environment is or what they lack, but also what is the purpose? Is this an opportunity for people to spring up, or is this people who have lost everything and now are dwindling away? There's this book that explores some of the challenges of slums, and it's called Planet of Slums by Mike Davis, and really looks at what led to this increased percentage of peri-urban environments worldwide. Is it just urbanization, or did some of the colonial forces that happened, in the past 2 centuries really affect people's economic and societal norms that now they end up defaulting to this environment. I think it's a very interesting discussion that this author brings up, and has raised a lot of different groups discussing some of his ideas. And he talks about his journey around different slums in the world, from Latin America to East Africa and South Africa, as well as Southeast Asia. This is a diagram just looking really at the world's population in the different geographies and who lives in slums. And you can see as the colors get darker, that means the higher the percentage of people living in slums. And very quickly you can assess that most of the people living in slums are concentrated in sub-Saharan Africa. There's a little bit in South Asia right here, but for the most part it's Africa that's getting most of the burden, and a little bit in South America. I wanted to talk about the African Institute for Mathematical Sciences. This is a very unique idea in my mind, and I was very excited when I heard about it about 4 or 5 years ago. Neil Turok, who's a South African, he's a theoretical physicist and mathematician who really works with Stephen Hawking and does very interesting theoretical mathematics and physics work. But he thought, well, here I am, a South African who came to Canada and now works at or has founded the Perimeter Institute in Waterloo. And he said, well, I'm doing some breakthrough research. I'm supported very well in North America. But unfortunately, Africa has been just neglected as as a continent that this will ever bring the next Einstein. And that's how this idea that could the next Einstein or the next Isaac Newton or the next whoever you want to, Marie Curie or whoever you want to talk about, is could that person come from Africa? And it's a very bold and daring idea, but I think it talks to not maybe an environment of despair, but one of hope. And so what he went about setting up was this AIMS, which is the African Institute for Mathematical Sciences. And over the next few years, he built a number of centers. Now there's 5 around Africa that really promote theoretical mathematics. And you see these young mathematicians coming in and are not fazed by any of the poverty or circumstances that they came from, but they can, through education and through very complex theoretical physics, are finding ways to improve their lives and finding new innovations and bringing some better governance even to their countries. And I'd urge you guys to look into that, because I think if we're talking about what the next, as we're approaching the singularity, or as we're approaching this point where technology becomes so I want to choose my words carefully, but as maybe technology becomes so pervasive in our society and the computing power of these technologies exceeds even our abilities in some ways, and then what does that look like? And is this a good thing or is this a bad thing? And are we ever going to be able to get to that point, assuming it's a good or bad thing, or will our societies continue to collapse? Now, before I talk about our organization, I want to bring up an idea. And this is maybe something we can pause and discuss. But I think the idea that Jared Diamond brought up in his book Collapse talks about formal societies as we know them nowadays, that they reach like a house of cards up to a point and then they collapse. But I think as we're moving in the next century, these peri-urban environments are providing a new way for societies to grow. And I don't think they're growing as just these increasingly complex systems, but I think they're growing as fractals. And they're complex in ways, but at the same time they have a certain simplicity to them that allows them to replicate very quickly and manage to unleash a lot of innovation and entrepreneurship, which I think might lead us to have the next breakthroughs in technologies, the next breakthroughs in markets, and next real Einsteins coming from these places that have slums, these places that have a lot of adversity, pushing them to really bring out the next best thing, because they're trying to survive. So I think while we're focusing on how do we integrate technology and how does the singularity look like for us, is it a good thing or a bad thing, and as we discuss it in this course, I want to bring this other aspect, that maybe the future global citizen will not be somebody who has rights and responsibilities traveling from here or going overseas, but it will be somebody from a peri-urban environment that came from an agricultural society and manages to develop something so novel and new that we all benefit from it, or we all are harmed by it. So I think we should not neglect that whole portion of the world that may not yet be obviously involved in this discussion. So maybe I'll tell you a little bit about who I am now, because we just went on a very theoretical thing. But I'm currently in my general surgery residency here at the University of Alberta. I'm in my 4th year of 5, and I'm training to be a surgeon. And while in medical school, or just before starting medical school, I started doing some work overseas, and over the next few years developed with a number of very intelligent and very passionate people. We developed an organization that we thought was a different way of thinking about bringing the next stage of innovation. And we set up an organization called IC Change, or Innovative Canadians for Change. And it came from this idea, really, that just looking at Canadians, how much do Canadians give? Now, annually, Canadians give $10.6 billion to different charitable ventures or religious affiliations, health, social services, but 6% of that going to international endeavors. That's great, and I think that's very important to note these figures, but what I'm more interested in is this. Canadians give 2.1 billion hours of their time to volunteering. Now that's the equivalent of 1.1 million jobs annually. So with 1.1 million jobs, if you could harness that just from Canada alone, what could you do? No company has 1 million employees. And what if now we can start to bring a portion of these people and get them to contribute their time and give them an organization that's able to manage their talent towards very real and tangible goals. So most people, I think, have these two ideas when they think of volunteering. They think, well, I'm either going to go overseas and pack my bags and have to go and spend time in, let's say, Africa, or I'm stuck at work, or maybe I can donate money because I'm working and can give money. But what if it's beyond that? What if we can combine those two and say that your job and your talent and your expertise can be crowdsourced and can actually represent a pool of talent that we can leverage and unleash incredible innovations very quickly? That was the bold idea that we tried to work with. Now, we came up with a model, and our model was an approach to innovation that really relies on initially finding a way of discussing with people who are bringing up an expressed need. So let's say an organization or a community or a country says, we have this problem, or we in our needs assessments identify a need. Then we look at how can we develop an idea, a model or technology for sustainable development, and we do that mostly through the talent that we recruit. So we bring people from all over the world, people from the UK, from Canada, from Southeast Asia, from Africa, and they all work together, and we manage them to unleash these models. Now, do we think these models are going to work? Well, we hope so, but we don't know. So we pose a question, and we frame it as a hypothesis. So, and most importantly, we work with local partners and have the central ethos of medicine, which is to do no harm. You can try to do good, but for the most part, we can, in medicine and, for example, in surgery, we can do a lot of things. But those things might bring some good. But the most important thing in the Hippocratic Oath is that to do no harm. We decided to embrace that as a philosophy for an organization. Now, we develop a hypothesis, and we test that hypothesis through an implementation. So we find a place that we think will really help validate this hypothesis and ask these difficult questions and go through the process of implementation and capacity building for that implementation. Run a very thorough monitoring and evaluation program that's external, that people are going to evaluate what we're doing and say, well, you guys are really not doing a very good job in this area, but these areas have some potential. And we involve local stakeholders who tell us we don't like this, we want this change, or we want to embrace this. And this process goes back and forth a number of times until we get towards some kind of, So from that point, we get some kind of best practices and a technology or lessons learned. And I think the crucial piece that we try to develop is a way to disseminate all the mistakes that we made along the way. From there, we can further enrich and develop IC Change, which is the organization that then now has services that it can provide. I know this seems maybe like a little bit of a strange way of doing things, but we can discuss some projects that I think might reflect some of those ideas. Anybody has any questions or any comments about that? No? Okay. So we'll talk a little bit about one of our first projects, which is the Kenya Ceramic Project. And it came from an expressed need that a number of people who were living in various different countries had come out and said that, well, we really lack access to clean water. So we thought, well, what would be the best way of developing a solution to that? And we looked at all the different literature, looked at all the different ideas, and developed this new technology. At the time, or at least we thought it was a new technology. And it was a ceramic filter, which was done by mixing clay, powdering it, mixing it with water, and then shaping it into what looks like a flower pot, firing it at hot temperatures, and you get a porosity and a permeability. You coat it with a silver colloid just to add more antimicrobial activity to it, and you put it in a receptacle with a spigot. Now this is a very important point, the spigot, because if you don't have that, people will lift the bucket or lift the filter and scoop with their dirty hands and recontaminate the water. So that was the idea. Could we make a point-of-use household water system that's made locally and very affordably and brought up to scale through local manufacturing and marketing? So we partnered with a local organization, did a needs assessment, and over the next few years built a factory that grew over time and then became the Kenya Ceramic Project. The factory now produces about 1,000 filters a month, and that's below its capacity, and over its lifetime has sold filters to families, and now the impact that we've had exceeds 100,000 people just from one factory, and there's been sales to about 4 or 5 countries in East Africa. It took a lot of work and took a lot of reflection. I don't want to belabor this project too much because I think it's just to bring up an idea of how to make a technology and how to go about implementing it. This is some of the tools that we use, the press, some of the insides. You can see all the filters stacked on top. And we test all of these filters to make sure that they meet a certain standard. Some of our workers, and as the project grew, it started to employ more and more people, and they learned the trade, and now they have ownership of the manufacturing and the marketing and the sales. See them stamping and quality control issues. These guys, I guess they're on a break. And just some more pictures here. This is some of the testing that we do to make sure that the filters pass. We do a flow rate testing and look at, well, are they passing a certain minimal threshold, or are they too porous that they're letting out bacteria, or are they too restrictive that this is just going to be a flower pot, really, it's not going to be a filter. So overall, this is what it looked like. So we had to brand it, we had to create brand awareness and create marketing campaigns, and it was called Ceramaji, which is Sera for the term ceramic, and Maji, which is the Kiswahili word for water. And over time, this grew as a name, and now in a lot of supermarkets, which is the very humbling thing, that people stopped calling these things filters and other people's products filters, they started to call them Sarah Maggi's. And so I'd go into a supermarket and I'm like, oh, do you guys have water filters? And they're like, oh, do you mean Sarah Maggi's? And then I'm like, sure, if you have those. So we go to the back of the supermarket, and it's not even our product, it's other people's products, people from Brazil and stuff, but that's become the colloquial term. So just like Kleenex is tissue paper, that's become the name in at least in some of the local markets, which is, I think, a crucial piece in starting to get the brand awareness and starting to get people to be willing to invest their money. One can easily run this project as, let's go there, bring some money, raise a very good cause here that, you know, we need to help them. Let's build a factory and manufacture these and give it to them. But will that help? Will that change anything? Will that improve their quality of life? And will they have ownership over it? When you look at all other people's mistakes and other people's lessons learned, we know that, you know, if you give somebody something for free, they may not value it. And the example of mosquito netting being used as chicken coop or fishing nets instead of, you know, them sleeping under it, because it was never marketed and brought into the collective consciousness that this is something I value. Once it was made into the discussions that we were having with them was really, well, how much are you willing to spend on this product? They were like, oh, well, we're not willing to spend anything. Just give it to us. And that's challenging when you're trying to run a sustainable operation, because you don't want to be funding it the whole time. And it wasn't until we reflected on, well, what are people spending their money on when it relates to this kind of topic? And it was antibiotics or going to the doctor. So individuals would be spending 3 or 4 times the cost of this product on their 2 children, for example, because of diarrheal disease, on the antibiotics that they have to buy to treat them. And once we got to that economic discussion with them, telling them that this costs a fraction of what you would spend every time your child gets sick, then people started to realize that, because we could talk until we're blue in the face about education and prevention and all that, but it really came down to addressing people's needs. Now, why did we choose Kenya? Kenya was one of the places that we decided was ready for this kind of intervention. They had a increased number of people moving towards urban environments. We had a country that spoke English, or had at least one of their official languages is English. They had a huge pottery industry, and they understood clay, and they had huge needs. Over 50% of the population in Kenya didn't have access to clean water. So this made it a clear and obvious choice to start. But from an operational point of view, this was important for us to not venture into a very dangerous country and set up an operation that may not succeed because it didn't have the necessary support. So we chose a place that was safe. I say that was safe because obviously there's some recent developments that have changed in Kenya, but it's still safe and we still continue to work there. So some of our workers cleaning some of the receptacles. The marketing campaign went out and started to get these filters, not at going to women's groups in the rural areas, even though a lot of them were starting to create businesses out of those and saying, well, we'll take orders, and that's one avenue. But taking it so that it's not a charity move, it's really something that they're investing in. We decided to go to the urban markets and focus on the supermarkets. So this was going to be something of prestige, that if you're going to go and buy a water filter, you can walk proudly out of the supermarket with it. People can see that you've bought your water filter. It's a natural advertising and education that you care about your family's health, and that water and sanitation is a priority for you. So right now, for our next steps for this project, because the sustainability of an initiative like this is, it's a multi-year project, and we're on our 7th year of running this operation. The factory is producing filters on its own. It's locally owned, and the marketing has successfully sold filters to a number of people. But we wanted to grow even more. So what we're doing right now, we're splitting the company into two companies. One is a marketing and sales company, and one is the production side of things, the factory. The reason we did that was some of the mistakes that we made, thinking that we could run this as one organization. But the supply and demand forces that the factory was facing, we get orders of 2,000 filters in a month. Now the factory would have to really start to put a lot of pressure on its resources and on its staff to produce these filters. Quality would go down. You'd have a number of filters not passing your quality controls. Your costs would go up. You would not be able to break even. And so what we decided was, well, in reviewing all the numbers and sending specialists that we crowdsourced, we sent people to do restructuring and reorganizational evaluations. And they came back, said, well, the market is ready to have a company grow the brand and grow the demand side while you guys are firming up your supply side. So we just came back from Kenya and have started the process of building this second company and have now a staff that's going to grow this Sarah Maggi brand name in a number of countries in East Africa. So, and it's those steps that, you know, if it doesn't immediately get the traction that it takes, well, we just keep at it and learn and make more mistakes and learn and make more mistakes. That's where we're at. I'll talk briefly about two other projects, and then I think I'll stop. But this project is a little bit more abstract, but I'll give you a little bit of context for it. Kibera is one of those slums or peri-urban environments. Sorry, the formatting kind of went wrong there for the clinics and insurance, but it's one of those peri-urban environments in Nairobi. The population of this peri-urban environments is debated. Some people say there's anywhere from 200,000 people to up to 1.2 million people living in an area as small as 5 square kilometers. Population density in some areas is 35,000 people per square kilometer. That's hard to fathom, those kinds of numbers. We got approached as we were starting to work with our water filters and marketing them and going to different places. And people said, well, there's a huge water and sanitation need in one of those slums. They said, could you come and sell filters in this environment? So we went, and they said, well, you guys are doctors. How about you help set up a clinic for us? So that was their expressed need. That was the expressed need of one individual. Now, what did the community want, and what did they need? So we asked them, well, how many clinics do you currently have? And shockingly, they had about 100 clinics. Every one of those red circles is a clinic that we mapped out, operating in isolation and competitively against other clinics. You can imagine what that makes or what that leads to when people are trying to seek care. It's going to be increasing costs. There's going to be people trying to prevent you from going to another clinic that might have the services that you need. And so the typical scenario that we found when we did our needs assessment was that a woman, and that's usually, unfortunately, who faced the burden, who had a sick kid, would go to the clinic and they tell her you need a chest x-ray for your baby. Now, the small clinic that she went to that's close to her house doesn't have x-rays, so they give her a requisition that she has to leave the slum and go on a 1 or 2 day trip to the district hospital or the national referral hospital to get an x-ray done, wait for it to be read, come back with the results, and then go back to her doctor, who then prescribes antibiotics. Or they just prescribe antibiotics even though this child doesn't have a pneumonia and he actually has asthma. So we thought that was, I mean, apart from the lack of continuity in healthcare, the lack of, these quick decisions being made that are needed, there's also a very huge opportunity cost for this woman to leave this environment that she's integrated in, that she has other children, she might run a store in that environment, and so her leaving is very, very costly for her. And many people who live in these environments are very entrepreneurial, like we were talking about initially. And in fact, this one area, Kibera, has been called by The Economist the most entrepreneurial place in the world. So her leaving for a day means that she doesn't have those maybe 100 or 1,000 interactions that she has every day to ensure that she has enough money to feed her children. So we said this is unacceptable, and this is not really what we're interested in. We're interested in imparting momentum, not really reinventing and building more clinics, because that's not what they need. You'd never be able to build enough clinics. So we decided to look, well, is there the necessary resources in this environment? And we saw that there were places that had x-rays, there were places that had labs, there were places that had ultrasounds, but because of the competitive nature, and no one would refer to each other. They'd all refer away from each other to try to keep the revenue. So this was going to be a challenge, but we thought, well, what kind of system intervention could we do? What kind of design of an idea could actually solve this problem? That's where we brought our team. We reflected on it, and we thought that really a medical record that's shared across multiple clinics would potentially solve this, but also create a paradigm shift in how people view this. And I'll talk about an example. So imagine those 7 clinics that we've picked. These clinics, for example, one of them might have, let's say my clinic, I have a lab, and your clinic has an x-ray machine. Now, normally, I might be able to make some money from me running my lab with my patients that I see, and I send patients for x-rays to the district hospital. But now we share a database, or we share a medical record. So patients coming to me might come from your clinic, and you tell them, well, I'm going to refer you to the lab in my friend's clinic there, and I'll be able to see the results as they get done. Meanwhile, I know that you have an x-ray machine, and I'm going to refer my patients to you. Now, people are not leaving. They're not losing as big of an opportunity cost in getting this. The system resource utilization is improved, and at the same time, it's breaking this competitive culture and leading to a more referral base, which improves patient outcomes. But without costing them anything, and if anything, our models show that their finances will improve, because now they're referring to each other, they're not competing against one another. So we picked a platform called OpenMRS, which is an open source platform. And over the next year and a half or so, we developed primary care, as in family medicine or first kind of point of care, electronic medical record. And the idea of an electronic medical record might seem like a strange thing to implement in a peri-urban environment, but our assessments show that, they were ready for it. It made sense. And then we were even more bold in saying that this was not just going to be an electronic medical record, it was going to be a cloud-based, networked clinic or system that every clinic can access over the cloud. And all they needed was an internet connection, that they could share the database across all of those clinics who fit the bill, who had the necessary requirements to join this. And it started to grow into a brand. Now, you can imagine as patients are coming to this, you can start to identify some patterns. So my clinic might see 200 patients a day, and of those, 10 patients might have cholera, which is a very common complaint in a place like a peri-urban environment. Do you guys know what cholera is? It's an infectious diarrhea that happens, or it's an infection in the intestines that cause a lot of secretory diarrhea, and people get severely dehydrated and pass away from dehydration. Because the more you drink, the more is going to come out, unless you drink solutions that are specifically designed to not get secreted, that get absorbed. So those are oral rehydration solutions. A huge amount of cholera happens in those environments, and a huge cholera outbreak happened in Haiti, and a huge cholera outbreak will happen in the Philippines after they are done getting hit with their typhoon, because that's what happens when you have stagnant water and lack of access to facilities. But let's say now in this environment, I see 100 patients, 10 of them have cholera, which is very infectious to other people. It's very contagious, and many people can get it. But this cholera, for example, if I were to put it on a map, that I have the medical record and I know where everybody lives, and we see where those cases of cholera are coming from, suddenly if all 10 cases are coming from one area that shares one water point, now that's an outbreak in the middle of starting to grow and really rage through the peri-urban environment that we can maybe thwart early and do a public health intervention. You can also extrapolate that to diseases like HIV, where you can start to look at resistance trends in the different virus and the different resistance to the medications that we use. Tuberculosis is something that gets aerosolized. So if I cough and I have TB, I can contaminate some people over long term, especially if you have HIV and your immune system is depressed. And you can start to do even more exciting things like targeting vaccinations, because you have a geographic information system or a map that has information on it that can tell you where to target your very limited resources. The goal of our project is not to solve all of these problems, but it's really to create a platform that people like yourselves can then create an intervention or work with the local people to do an intervention. And instead of sending, let's say, I raise money and I'm going to send $100,000 to help this community. Now you can target that intervention and have better outcomes. I think this is my favorite idea is for most of the work that we've done, I think this is still, in my mind, probably the most challenging, but also one of the most daring things. The concept of health insurance. Now, a lot of you are familiar with insurance, and insurance is really a ratio of risks to premiums. So a young man who drives a car is seen as more risky than a young woman driving a car. Now, there's a lot of men in the room, and we all know why that might be the case, but statistically speaking, we take more risks and get into more accidents. So the insurance companies charge us more money because we might use our payoffs more. And so that's how they plan for it. For health insurance, if I'm seen as high risk, let's say I have a pre-existing condition, or I come from an environment that's known, or a genetic line that is known to have problems, let's say cancer, then the insurance companies might try to charge me more, which raises a lot of ethical problems, which we can start discussing hopefully at the end. But now, unfortunately, when you look at a place like Kibera, which has a huge number of people, and is the norm of the environment in Nairobi, and a scary statistic, and I'll just pause and tell you the statistic, scary statistic that we know is true now, that 60% of Nairobi's population lives in slums or in peri-urban environments. That's a staggering number. And if that's the reality of everybody that lives in these environments, that's the scale that we're talking at. So these insurance companies look at slums and they say, well, these are very high risk overall, and that we would only offer them a very high premium. They don't stratify the risk for individuals. Alternatively, people might say, well, let's go with aggregated risk for insurance, and those are what you might hear about called microinsurance. And they say, well, okay, how about if we get 1,000 people and we charge them all a little bit less, and they all pay the same premium, and then they can all benefit from the economies of scale of them investing in their premiums. But that may not be sufficient for people who are in the lowest socioeconomic stratas, and they may not be able to actually get enough resources to fund their health insurance. So what we decided was, well, okay, could this medical record act as a tool for advocacy for the patients? Now, I might be seen as high risk because I live in Kibera, and I might be seen as high risk because, let's say, I have HIV. So the insurance companies might charge me $100 a month. But as I'm showing them through the medical record, and I can take my medical record because it's documented over all my encounters, and I can show them that I'm compliant with my healthcare, that I seek my appointments on time, that my blood work is consistently within the normal range, that you can start to bring down your premiums by making a case that you're not high risk. So the paradigm shift that happens is that you're not spending more money to get healthier, but instead, by getting healthier and by investing in your healthcare, you're saving money. And this idea, and some of you who are involved in this work might hear about universal health coverage and what that means globally, and the UN has just made this one of their priorities, and the WHO has made this a priority, that universal health coverage, whatever that means, in one way or another, they all should be universally covered. It's going to be a challenge for situations like this. And if this is the new normal, if this is the societies that we're going to be dealing with in the future, then should we not be proactive and start to approach them with the foresight that's needed, that as this becomes the new normal, this is what we're going to be implementing? And that's what we're trying to do. So now this is where we get a little bit excited and a little bit crazy, but how do you ensure that you have enough internet access in a place that doesn't have the necessary infrastructure for internet access? So, we've made partnerships with some local organizations that are the big telecoms, and they charge a significant amount of money, often close to being prohibitive for clinics to participate in the project. We thought about it and said, could we potentially create a hotspot, an internet Wi-Fi hotspot over all of Kibera as a model for providing internet to all of these clinics, and in the process provide internet to countless people who may pay a very small amount of money, way less than what anybody would pay, but would give them access to internet, will give them access to voice over internet calls, and give them access to WhatsApp and those other messaging tools. But at the same time, if we believe, which we do, that internet is a human right, more and more these days, and that access to information is a human right in this day and age, that you can say in all the schools that are in Kibera, we'll provide free internet, and in all the clinics, you provide free internet, and your social enterprise, which is the company you're setting up to build this Wi-Fi network, can then grow these economies of scale and provide a model of sustainability for a project like this and a source of revenue to propagate it. And that's some of the next steps that we're taking in challenging ourselves to think outside the box and grow things that are not the typical, slums. Maybe they can use the leftover kind of bandwidth. Well, no, what if we invest wholeheartedly and say that, no, this is going to be the best Wi-Fi they have? The population density in that area is enough to generate, in small bits, huge amounts of revenue to run a very successful business and create more and more social benefit. This is not to create a for-profit, but it's to create a social impact. Okay? The last project I'll talk about, and this is more related to what I do kind of day to day, being in surgery, is the Kenya Trauma and Injury Program, or KTIP. Now, Kenya has a population of 41 million. It's been the recipient of donor support for decades. It probably has what we would consider 2 tertiary care hospitals in the country. They have 60 intensive care unit beds. They have a huge burden of trauma and surgical disease. Now, trauma and injury, maybe this is a new topic for some of you, but infectious diseases were kind of the big realm in the world, and everybody who talked about global health and global development focused on HIV, TB, and malaria. And now as we look at people living longer and longer and population densities increasing, you have more non-communicable diseases like heart problems, cardiovascular risks, diabetes, hypertension, and surgical disease, as well as cancers. And one of the big problems that happens as people get more and more urbanized is they get into car accidents, and there's more and more motorbikes, so people start to get more injured. If you look at just trauma, we're not even going to talk about non-communicable diseases, but I can tell you right now that 60 to 75% of diseases globally and the causes of mortality are not from infectious diseases. They're actually from non-communicable diseases like heart attacks, just like we have here. So it's getting more and more similar, that we're starting to have more and more of the same risk profiles because our dietary habits and our lifestyles are changing. But trauma and injury are the leading cause of death in the first 4 decades of life, primarily in men, primarily in the income generating bracket, which is the first 4 decades of life. And this important number is that the burden of mortality from trauma and injury is bigger than TB, HIV, and malaria combined. So for all those very successful projects that have been done for HIV and malaria, we're unfortunately neglecting this very large portion, which is traumatic injuries. And most of the reasons why that's been neglected is that it's traditionally been seen as an infrastructure problem, that in order for me to operate on people and deal with traumas, that we need very big hospitals like the University Hospital, the Royal Alexandra Hospital, or big centers to deal with it. And the infrastructure that's in place, and we'll talk a little bit about that, has traditionally been built in most of the developing world without any regard for urban planning strategies. Now, maybe the first iterations of the hospitals and stuff, but as more and more hospitals and centers and not-for-profits and well-intentioned people come and say, well, I know Father Joseph has some land, how about we build a Pimpin dialysis unit on Father Joseph's land in the middle of nowhere that no one will ever get to. And that's unfortunately what happens in most of the world. This is also the reality of most of these countries. This is the roads that you have to deal with. That if you're, imagine you're in a trauma and you have to travel along these roads, I mean, what are the chances of you being, protecting your neck and your collar so that you don't get any spinal cord injuries? I mean, even if you're not in an injury, you might get a spinal cord injury traveling on these roads. So we decided to ask a question, was, well, is the infrastructure in those countries, is there a way of using what's currently available without adding any more infrastructure and using it more intelligently? So we used this idea of a geographic information system again, and this is a map of the western part of Kenya. And we have projects in about 4 or 5 countries, but I'm just focusing on Kenya because those projects are further ahead and they're also easier to present. But this is the map of Kenya. This is the western part of Kenya around a city called Eldoret. Do you guys know the concept of the golden hour? Have you heard of that? So if somebody was in a car accident, as you know, doctors, we think that the first hour is critical in them surviving. If they get to a doctor or somebody who's well-trained in handling traumatic injuries, they have a much better chance of surviving. So we said, well, how long can I travel in an hour in Western Kenya? And we estimated that 50 kilometers was about as much as we can do. So we decided to map out all of the infrastructure, all of the health infrastructure in a 50-kilometer radius around around this one hospital in the city of Eldoret called the Moi Teaching and Referral Hospital, which is a big tertiary hospital. And you can see, can you imagine that this is the number of clinics, hospitals, district hospitals, and referral hospitals that exist in this 150-kilometer radius? A level 5, which is in the middle here, you can see it in this blown up point, is the referral hospital. This is kind of the big, like the Royal Alexandra Hospital. The level 4s would be the equivalent of, let's say, the Grey Nuns Hospital. This is how many of them exist here. But anytime an accident happens out here, they bypass all of these guys and they come straight to Moi Teaching and Referral Hospital. They bypass all of that infrastructure. Any physician that might be there might be able to help them because they don't believe that there is enough trained capacity, nor are the clinics ready to handle traumas because they don't have the necessary training. This is a different topographical view of this. This is some pictures of what a typical hospital would look like, and this is the National Referral Hospital. This is their emergency trauma bay. You can see it's pretty decrepit. To be honest, these 2 monitors don't work. This is just for show. And so you end up measuring pressures and stuff by hand. This is some suction devices that don't work. This is one of the stretchers that they use for resuscitating people. And this is the most important equipment. So laryngoscope is what we use to put a metal thing in somebody's mouth and then put a tube to intubate them. Unfortunately, it's locked. and the person who had the key wasn't there. So if there was a trauma that had happened there, they'd have to find whoever it was who had the key, or break the lock, and then try to get whatever equipment might be in there, and there might not be anything. This might just be a sign that says laryngoscope. And this is the referral hospital. So we decided that, okay, we're not going to accept this as, the norm, that maybe we can do more, maybe we can design a system for trauma. And we started working with the ministry, started working with the Kenya Red Cross, which was providing a lot of the paramedic care to a lot of patients. And they had, with 34 ambulances, they had the largest fleet of ambulances in the country. 34 ambulances for a country of 40 million. So we started to think about it. What are the main categories of trauma care? Now, there's policies. So all of you guys here who, if you don't wear your seatbelts, might get a ticket, that's a law. And that comes down to policy and fighting for that law, that you have to wear helmets, that you have to wear seatbelts, that you can't text and drive, that you can't do all these things. So that's the pre-injury side of things. Because the biggest kind of impact you can have in trauma is not in once they're in an accident, but it's in preventing it. Because once they're in an accident, now you have to have somebody like me dealing with somebody like you, and you don't want that. So the pre-hospital care means if the accident happens, now somebody has to coordinate going there, picking you up. There has to be a 911 number, which there isn't. There has to be somebody going out there, fetching you, putting you in an ambulance, and then driving you to the correct location. Then you have to have the necessary training for the people to triage you appropriately. Well, you're a low mechanism injury. You shouldn't go to the big hospital, because the big hospital should be safe for the very complex cases. You should go for a smaller hospital that can take care of you, maybe fix your broken leg, and then send you home. So that's the triage and transfer criteria. And then for hospitals, now you have to start thinking about what are the challenges that they face, what bottlenecks do they have, and how can you audit a big hospital to tell them this is where you should really focus your efforts. And then the single biggest deficiency that we've identified and that they've expressed to us is rehabilitation. Somebody with a spinal cord injury in East Africa right now is on a 2-year wait list to be seen by a rehabilitation program for spinal cord injury. In 2 years, I can tell you that you will never regain anything that you might have lost. You'll have infections and you'll probably die. So, and again, we're saying that this is the largest cause of death in the first 4 decades of life. So you're losing your most productive members of society early. And you're leaving behind women and children to have to find employment in environments that sometimes might be austere and sometimes might be very difficult culturally to get. Older people who may not be able to work, expectancy. So we started to say, well, you know what? What if we could decentralize trauma care away from the big hospitals and send it to the smaller centers? Instead of them coming all to the big hospital, we're going to choose the sites that we think are the best, and we're going to train them by developing a training program or bringing in an established training program called Advanced Trauma Life Support. Some of you might have heard of ATLS, which is what we're all trained in. And so as long as you come in front of one of us, you have a much better chance of surviving within the first hour or so if you have that kind of training. To bring that kind of program, you need a national body, which didn't exist. So we created, working with the appropriate players, we created the Trauma Association of Kenya. We've developed the geographic information system for the country. We started developing a trauma database to collect, because you need to understand, well, what kind of injuries are you seeing? Is it all stabbings? Is it all bad car accidents? Is it falls? What is it? So we created a trauma database and see how are we doing. And then we started to create this paradigm shift of decentralizing trauma care. And like I said before, the dissemination of advanced trauma life support principles. And not just training doctors, because that's a huge deficiency that exists in most of the developing world, but training nurses and nurse practitioners and clinicians in how to approach these very algorithmic approaches to treating patients. We worked with the Kenya Red Cross as one of our main players and have now just won a grant to implement the first phase of this project, and this has been presented to the President of Kenya, who's approved that this is a priority for them, and it's starting to be the national response and national trauma and injury framework for the country. Now, recently you might have heard that there was a terrorist attack in Nairobi in one of the malls called the West Hills malls, the Westlands malls. And when that happened, they realized the true deficiencies of the system came out. They had 100 people that needed immediate care, and they were right in the heart of Nairobi. This isn't like some long distance. And they had 70 die. The 100 patients, unfortunately, went to a few centers and immediately overwhelmed those centers. And there was no easy oversight other than the Kenya Red Cross to really come in and take control of that situation. So that night, the Deputy Secretary General for the Kenya Red Cross called us and said, right now it's become really obvious that our trauma systems are very inadequate, and we've been working on this for the past year, but now it's time to really push this forward and start to implement a lot of these things. So we just came back 2 weeks ago from Kenya, having launched and signed a lot of the documents, and now this is going into policy, that this is going to start to be the new norm. Now, will this work? I'm not sure. Does this have a chance of working? I hope so. And the way we're going to take this forward is by involving as many people that have the appropriate talent and skills to constantly evaluate what we're doing, contribute, and hopefully impact in a meaningful way. That if the low and middle income countries that make up the majority of the world's population are moving towards increasing urbanization, we presented to you 3 challenges in terms of water and sanitation, access to medical care, both for medical records and health insurance, and the burden of the single biggest killer, which is trauma. And these are some of the things that we're developing as an organization, models of how to do this. And we invite you guys to make the discussion even more relevant, even more important, and challenge us to do better work and join us. Thank you.
So, questions?
Hello, my name is Brad.
Hello.
I'm just wondering, so you had the flow chart with your steps to kind of going about taking on these initiatives. That's kind of in the beginning section of the presentation. I'm just wondering, so what steps do you take to come up with your ideas, and how do you get people involved? Like, how do you crowdsource people?
So, in terms of how we come up with ideas, a lot of it is by being available in the right places. And so we go to all of the major places that are driving innovation, that are talking about the most complex problems of our times. So we were just at the World Health Summit in Germany, talking about some of these big challenges. We've been to UN meetings talking about environmental, sustainability and the burden on the environment. We try to be there, but not just in those big organizations, because I think, unfortunately, they also lack the momentum to do this, but talking at the grassroots and being there and not being afraid to take a risk. That if there is a new opportunity, for example, right now, somebody who'd heard about some of the work we're doing came to us and said, well, I have an idea for additive manufacturing or 3D printing of surgical instruments. Now, surgical instruments are a very complex field, but this person came to us because he'd heard about what we've done. So our marketing, our work, and talking about what we do is crucial. He came to us, and how we go through that process is by us being as open to new ideas as possible, and not say that this is our ideas. No, these are our objective is to improve the lives of vulnerable populations. So you come in with an idea, we will support you to deliver. If we ask the tough questions and it seems like a valid question or valid concept, then we'll support you through that. So now we've supported him, and now he's starting to get some real traction, and we're working and supporting him fully to do that.
I'm also just wondering, can you talk a little more about who makes up the IC Change group?
Who makes up IC?
Yeah, so yourself is obviously a founding member,
Yeah.
but who else is involved in that?
So we have an executive of 9 people that come from backgrounds, various backgrounds: medicine, business, engineering, and some, nursing and other health professions. In terms of the services that we have people from that support the projects longitudinally. There's people from geomatics or geographic information system people. There's people who are software developers, but our biggest contributors are kind of a global network of people that come from financial sectors, come from engineering sectors, and universities. So we plug into a lot of industries and a lot of universities, and that's who makes up the biggest part of our network. But the core group really is about 20 very committed people, primarily in Canada. The bigger group is probably about 120 worldwide of people who work on projects day in, day out. And the bigger network is kind of nebulous because more and more people come in and out. Yeah.
Hi, my name is Opie, and I'm part of another group. It's called SIHA, Students International Health Association. I don't know if you've heard of them.
I have, yeah.
Yeah. So we did a similar project with you were talking about the ceramic project. I was wondering if you guys also looked into the biosand filtration. And I'm just curious as to how this system works, like in terms of the technicalities, how it removes parasites and bacteria, because it doesn't seem to have like a sand filtration or anything like that going on.
It doesn't seem to have a...
sand filtration or anything like that going on.
So there is, when we were starting to do this, and part of our process is to evaluate all the currently available technologies, and if we don't feel that there's something that's currently available that fits the bill, then we work on developing something new. We assessed biosand filters, and I did my undergrad in the University of Calgary, and that's where Dr. Mans is, who developed the biosand filters. In my opinion, I think they are a very good intervention, but they are fairly complex to manage at the household level. So in terms of changing and setting up the different layers and cleaning it, if there's any problems with it, growing that biofilm on top, it's more complex, and we always say that this is a very appropriate intervention for a school or a clinic. In terms of the household level, you want something that doesn't take a lot of care and a lot of upkeep. So this ceramic filter is very easy to use. It's cleaned once a month with a brush using some of the filtered water, and you just clean it. And so we don't say this is better than the biosand filters, but studies that looked at the efficacy of them overall show that ceramic water filters overall exclude more bacteria, and probably on the order of 95 to 97%, whereas biosand filters probably exclude 85 to maybe 90% of fecal coliforms overall. And that really takes into account how people use those technologies, whether they're using them appropriately. In terms of the filtration mechanisms, there's 2 mechanisms to exclude organisms. The first one is size exclusion. So as we get the filter gets filled with water, you have the porosity and the permeability inside that, and the tortuosity of the path leads to probably an effective permeability of about a micron, which is a little bit smaller than most bacteria. And a second layer of a colloidal silver gets embedded into the ceramic matrix, which inactivates the bacteria and the parasites that are in there just through contact. Because as you know, silver is antimicrobial, or at least is bactericidal.
That makes sense. I just want to let you know, though, we did implement a pilot program at the household level with the biosand, and so far it's, from what we've heard in terms of updates, it's been a huge success.
It's wonderful. Congratulations. That's It's very good work.
We're out of time, and thank you very much. I think that there were a lot of brand new things in this, and I really, appreciate the effort that went into it, and probably see a much larger audience than the few that are here on this official university holiday. So thank you very, very much.
Thank you.
Yeah.